sexual dysfunction is a very important aspect of quality of life as defined by the World Health Organization. So now, next slide, please. Next slide, please. So Mr. Omar Agaisa needs no introduction. By this time, you heard so much about it because today I have already given 3 talks and all those PRISMA had been done by him. The research results are double checked by Suhail Al-Gabish, and between the two of them, they seldom argue or quarrel about which study they should include. But in case there is really discrepancy, they have a third person who can sort of say, yeah, I like this, I don't like this, and make the final decision. Okay, so next slide, please. Over half of the melanoma patients have sexual dysfunction. You can't believe it. Women tend to struggle more about body image, fear of cancer recurrence, while men were worried about erectile impotence or hormone-related, sort of giving them menopause as such, particularly from immunotherapy. And this review will highlight major gaps in clinical recognition and support, emphasizing the need for routine sexual health screening and multidisciplinary care in melanoma survivorship. Because melanoma had greatly improved outcome in the past 20 years. So nowadays, even stage 4 melanoma patients can look forward to long-term survival. And they were not just talking about being alive. They have to be alive and well and enjoy sex. Next slide, please. So sexual dysfunction affected about half of the, oh, no, go back. Half of the melanoma patients with a higher prevalence in men, almost like 70%, and women like 40%. The contributing factors would be visible scarring, hormone imbalance, testosterone deficiency in 70% of patients receiving immunotherapy, body image concerns, anxiety, depression, and sexual health concern is indeed very important. We have a lot of gaps in longitudinal data. There were cultural considerations, and then there were also trouble with the evidence-based intervention. So routine screening and integrated psychosocial support are very important to improve patient-centered survivorship care. Next slide, please. So Mr. Omar Agaisa have done search across 5 major electronic databases, and PubMed, Medline, Sinho. I think Sinho is a sort of nursing health database that our Sutuna University had it. And he had used PRISMA, preferred. Oh, too fast. Preferred. The PRISMA method to do the analysis. So the PRISMA, the long name for that, just in case you miss it, is Preferred Reporting Items for Systematic Reviews and Meta-Analysis Extension for Scoping Review. It's a long name. Now, what are the inclusion and exclusion criteria? They are listed. So he had include clinical trial observation studies, case report, meta-analysis, etc. That will eliminate the sort of in melanoma treatment. And then the exclusion criteria, he only focused on English study. But I can guarantee that there are not much about in the French literature or in the Chinese literature. Most of the important studies are all in English. And now he initially found 400 papers. And finally, the exclusion criteria, some of them are duplicates, some of them don't even talk about melanoma specific outcome. So particularly on sexual dysfunction. So finally, only 10 studies get narrowed down to be included. And that's the Prisma flow diagram. So the next slide, please. So this scoping, oh, no, okay. Okay, go back then. I'm not yet talking to a conclusion. Okay, you still have to enjoy my talk a little more. So the research question would be, what is the current state of knowledge regarding sexual health issues in melanoma patients? And how can these issues be addressed or managed? And this is using the Population Concept Contest Framework, PCC, Population-Concept-Contest Framework. So it talks about sexual health issues, dysfunction, related interventions, and also in different oncological care settings and survivorship programs. And there is a quality appraisal done. Actually, every scoping review and every systematic analysis has a critical appraisal. That means they give a number. High rated score 7 to 10 is good. Moderate only score 4 to 6. Low is 3 or less in terms of their quality. So then after the data extraction, a big table was built with the author and listed their findings like a big table. But because the prints are so small, I don't bother to include it in the slides at all. So the 10 studies are ranging from 2017 to 2025. So this scoping review is only focused in the past 10-year data because the older paper, they may not have the new immunotherapy, all the modern treatment, and the sort of surgical treatment may be old-fashioned. The radiation dose is not good, not modern enough. The radiotherapy technique is not good enough. So it's not pertinent to current day medical practice. And that may be the beauty why we just chose the last 10 years, okay, for this review. So there are different outcomes that we look at. The study population, I told you, is focused on English literature. Then it talks about the prevalence of sexual dysfunction. And as said, there were roughly about half of the melanoma patients in Spain that have been reported to have sexual dysfunction, according to an author, Munoz Baba, just published this year. And then another review from Hain in 2023 find also, again, nearly half of the long-term cancer survivors have sexual dysfunction. And so, then we also look at the gender-specific differences in sexual health, and I've already told you that women were worried about body image, they worry about recurrence, and men obviously worry about erectile impotence. And well, women also have a higher risk of thyroid-related adverse effects with systemic treatment. They have dermatological complications from target therapy, all those rash, itchy, and ugly, okay? And that could indirectly impact sexual health through their body image concerns and hormone disruptions. Now, there are hormone effects. Testosterone deficiency was found in 70% of the patients by Peters et al. In 2021. And he emphasized that clinical recognition is very important. You have to manage it. Now, there is also hypophysitis. That means inflammation of the hypophysis, the pituitary gland. That's associated with hypopituitarism, and obviously pan everything down. FSH is down, LH luteinizing hormone is down, follicular stimulation is down, prolactin is down. Your sex desire is all gone. That's the bottom line. Okay. And so this physical symptom burden had a stronger impact on sexual satisfaction, even more than your psychosocial factors. That's what Hein in 2023 found. And so this paper is going to be written up and is in the process of submission. So you don't have the luxury of seeing the full paper. I'll try to put the research gate, this PowerPoint very soon, today, so that you can read it in detail. Now, about the body image, I've already told you earlier, like a huge lymph node in the neck resulted in a long scar in the neck. And women will feel very embarrassed to undress during sexual intercourse. And not to mention that if it is in the axilla, you can end up with lymphedema of the arms. But good news is there is something called lymphovenous anastomosis. That means the lymph vessels are joined to the lymphatic channels so as to enhance the flow of the lymph, and therefore the patient will not look like a big, with hands like very fat. They cannot put on their rings. They appear sexually unattractive. So, is in fact the patient's perception is important too. They have to think positive in order to act positive. Everything comes out of your mind. So now treatment-related issues, there are many of them to mention. I told you about hypopituitarism, testosterone deficiency, and then there is also the emotional well-being. Sometimes patients get depressed. They worry about their own health too much. Now, I mentioned that there could be some gaps, and I would suggest that actually to address them in future research. Most of the studies that we found were cross-sectional in design, and they limit the understanding of temporal relationship. That means over time, how will things change? You don't know that. And additionally, several studies have mixed cancer population, not just melanoma alone. And they do not have specific sexual health assessment. And so it's really difficult to isolate melanoma-specific sexual health problems. The geographic distribution of published paper is also limited, mostly in European countries and United States. We need more paper from the Far East, from the Middle East. And in fact, actually, those ancient civilizations like Egypt, Arab, China, India are very conservative about sex still to this day. Now, chemotherapy-induced menopause, we should do more study about it. So there are also the patient's perception of quality of life. They need more psychologists to help them out. They may need marriage counseling. All these needs need to be addressed in a multidisciplinary clinic. We need the administrator to think of good protocol to help all these poor patients. So the mental health professionals, psychologists, are all very vital, the key to their best healthcare. So obviously, I told you the current evidence have limitation. They do not have long-term studies, and some of them are self-reported questionnaires that have subjectivity. They have recall bias. They have social desirability effects they want to tell others that appears to be so embarrassing to mention. There always is stigma about sexual health, and therefore all sort of questionnaire may not really reflect the whole reality. So the direction for future research, we need to look at the pathway, the temporal pattern, more evidence, more effective management strategies, rehabilitation interventions, targeted psychosocial, pharmacological ways how to help sexual function. And obviously, the kindness from the heart of physicians and nurses who are in healthcare profession to look into this very important aspect of quality of life, dedicated the time and the effort with continuous professional development to develop skills in sexual health. In conclusion, now we go to the slide of conclusion. Please, can you advance the slide to the conclusion slide? The conference organizers, please. In conclusion, this scoping review have a comprehensive synthesis of the existing literature on sexual health issues in melanoma patients. We have compiled existing research showing that sexual health have been not published too often, is underrepresented in melanoma research and practice. Despite the fact that quality of life, psychosocial well-being, and coping mechanism still need a lot more attention. Intimate relationship issues, diminished self-esteem, changes in body image are common complaints from patients. Could you please advance the slide to the conclusion slide, please? So the intervention study are not enough in terms of depth, and they lack cultural diversity. They don't have longitudinal data. We need increased clinical awareness. We need systematic screening for sexual health needs. And we need to create patient-centered evidence-based interventions. And further studies would need to pay attention to cross-cultural viewpoints, incorporate patient and partner voices. It's important to include the partner. And assess the efficacy of educational and supportive initiatives aimed at enhancing sexual functioning. And at this time, I would like to acknowledge the collaborators of this great research work. Next slide. These are Professor Kieran Joseph, Mr. Calvin Wong, Professor Edward Yu, and myself,